morning, ladies and gentlemen. I am Dr. Mohua Shikdar, consulting diabetology in Bardhaman and in Kolkata. Today, we are going to discuss about a single small wonder pill, which is a combination of empagliflozin and linagliptin, and it's used in the management of type 2 diabetes. So for which we have none other than Dr. Debmallo Shannal, who is a renowned endocrinologist of our country. He is actually a consultant endocrinologist in R.N. Tagore Hospital, Kolkata, GD Diabetes Hospital, Kolkata. He has multiple numbers of publications on his account. He is a good clinician, big researcher, and he is a very, very known face of all different diabetes and endocrinology conferences of our country. He doesn't need any introduction. If we try to do that, it will be very, very small than his actual experience, actual knowledge, and actual excellence than it actually is. So without much more wasting time, let's dive into today's topic. Debmallo, we welcome you wholeheartedly in today's discussion. Please join us.
Thank you, and thank you for the kind introduction.
Yeah. Debmallo, we actually are dealing with type 2 diabetes, and we know that especially I deal with only diabetes patients, and I get to see diabetes patients in a vast majority of population, right from the onset of diabetes, diabetes with risk factors, diabetes without complications, diabetes with complications, and also diabetes with end-stage illnesses. So in this vast majority of diabetic population, what do you think where this wonder pill of single dose of EMPA and Lina fixed dose combination is actually fit for?
Well, very important and pertinent questions. And as you have said, that the vast experience which you have had, you must also have realized that this molecule actually has its presence or indication right from the beginning. Yes. Almost till the end of the diabetes journey. Because if you see with regards to most of the recommendations now, most people are recommending combination therapy because there are multiple pathophysiological defects in diabetes. So you need to address most of them. And yes. Secondly, with one agent, the failure rate after long term, it will be much higher. So durability of therapy, any therapy, monotherapy is very short-lived. So we have to have agents, multiple agents to address the glycemic control. Second is we nowadays are not only focusing on glucose control, but also on organ protection like kidney, heart, and now even also liver and nerves and eyes. So most important with regards to cause of death in diabetes is kidneys, yes, that is renal failure, and also cardiovascular disease. And if we look at these molecules, they are not only safe in terms of cardiovascular and renal outcomes, but if you look at empagliflozin, it improves the renal outcomes, it improves or decreases the chance of kidney failure in the long term. Albuminuria, not only that, it decreases the chance of heart failure and also improves mortality. And in patients also with cardiovascular disease, it prevents cardiovascular disease as well. So we have a host of benefit, not only apart from its glucose reduction, it has an important feature with regards to weight reduction, it doesn't cause hypoglycemia, and on top of that, it has cardiovascular benefit and renal benefit as well. And the combination of DPP-4 inhibitor and empagliflozin have additional glucose lowering capacity, which is more than 1.5%, around 1.5%, which most of the oral anti-diabetic agents will not able to achieve. That's why we require combination therapy. Moreover, empagliflozin has more of its effects on fasting with DPP-4 on PP, and there is less chances of any fungal infection with this combination. Furthermore, the risk of rare complication of diabetic ketoacidosis is also much less with this combination. So we can use it right through from the beginning till the end, but more so in patients with any cardiorenal problems, including cardiovascular disease, chronic kidney disease, heart failure, these agents are mandatorily recommended,
Right.
especially for protection of heart and kidney.
Right, Devmalada. That is why very well you described about diabetes, because diabetes, when it comes to a person's life, it doesn't come alone. It always bring together all other comorbidities such as high blood pressure, high body weight, and other comorbidities associated with this. And we know that prevalence of cardiovascular disease is quite high in type 2 diabetic patients. In every 3 diabetic person, at least one will have any type of cardiovascular disease. And from a survey from our country, that is a OPD survey, which is called iCare survey, which was done in 2018 across more than 300 diabetes OPD of our country. Here, actually, Dr. Kalra, Dr. A.K. Das, or those who were involved in this survey, where they found that nearly 59% of patients with type 2 diabetes in Indian OPD setting have high chronic kidney disease risk. So cardiovascular risk is also high, and chronic kidney disease risk is also very, very high. So with this, we know that there are vast majority of emerging evidence of cardio-renal metabolic risk reduction modification. And with all experiences and evidence and the pleiotropic benefit of the single wonder pill of empagliflozin and linagliptin, and how do you bring together all these evidence with lower risk of genital tract infection and with the help of this wonder molecule, wonder pill?
So with regards to, if you see, we have to get our control very early, as has been seen, in the UK PDS, and also recent studies showing even the first year of control getting to target HbA1c less than 7 is very important to prevent the cardiovascular risk and cardiovascular mortality. So that is very important to get it to target within the first year itself and persistently maintain the target. And so this combination will be very useful in terms of lowering glucose, weight, without any additional risk of hypoglycemia, and having a cardiorenal benefit. So we should try to achieve good control and as tight control as possible early on to prevent cardiorenal benefits. And also, if we can achieve long-term control, we can prevent the cardiorenal outcomes. And if patients come to us with established cardiovascular disease or established renal impairment above CKD4, then we should definitely it is recommended to use this combination or this group of medications to prevent further progression of cardiovascular disease, heart failure, cardiovascular mortality, as well as renal failure, renal transplant, and death. So very important, especially with empagliflozin, there is a very strong evidence with regards to reduction of the hardest endpoints, that is total mortality and cardiovascular death, apart from reduction in renal outcomes, dialysis, renal transplant, and renal death.
Yes, right. In this context, I just want to mention about EMPA kidney trial. We know that EMPA kidney trial is the largest SGLT2 inhibitors trial in chronic kidney disease patients till date. And it includes a broad spectrum of adults with CKD, including people with mildly to severely reduced eGFR, with normal and increased level of albumin, and more importantly, with diabetes and without diabetes patients. And we know that this trial independent data monitoring committee will be recommending that the trial will be stopped early due to the evidence of the trial treatment is more effective than the placebo. So, but details we will get to know in the later half of this year. So do you think, Devmaluda, that after EMPA kidney trial, the usage of empagliflozin will be more, or rather usage of empagliflozin, where already linagliptin has got his score in the kidney zone. So with this EMPA kidney trial, will this combination will be much more effective? Do you feel that?
Yes, obviously, because we already know that linagliptin is safe with regards to renal impairment, as well as in CKD, even in patients with dialysis, and we have also shown in patients with transplant as well. And now with the early results out of the EMPA kidney trial, which has shown significant benefits across different population subsets, early diabetes with CKD and even with late CKD, both not diabetes and non-diabetic subjects. So the use of this combination will be more effective and more it will increase significantly. Very important to point out that with regards to DPP4 inhibitors, we need to adjust the dose of medications with regards to GFR, which is not required with linagliptin. And
Yes.
empagliflozin, as we have seen, can be used right up to the stage of, if it is initiated before a GFR of 30, it can be used right up to the stage of dialysis, that is stage
Dialysis.
4
Yes.
CKD.
Yes.
So this combination can be reused without any dose modification right up to the stage of dialysis.
Right. Which brings us today, my last question of the day. See, for any the success of any drug depends on the tolerability. So, what is your thought on this tolerability of and compliance of the particular molecule? See, since it is a single pill, and what is your thought on this tolerability and compliance of this molecule for the long-term management of type 2 diabetes?
So, as we are all aware, that diabetes and any chronic disease require compliance, and the compliance, as we are all aware, decreases, the adherence decreases with number of pills, increasing number of pills. So if we have a single combination where the dose modification is generally not required, then this is very convenient, and the adherence to therapy will significantly improve, and that also translates into better outcomes, better control as well. And with regards to tolerability, as we are all aware, as we have discussed, that almost other than past history of pancreatitis, there is no contraindication of linagliptin. And similarly, with regards to empagliflozin, they are well tolerated. Only the small minor side effect generally, which is rarely seen, which is sometimes seen, is the genitourinary infection, especially the genital infection. Other than that, and that too, the risk is decreased if this combination is used. And
Yes.
previously it was thought of acute kidney injury. Now it has been suggested that actually it is better in terms of acute kidney injury, which is lower than placebo, so it's protective against acute kidney injury as well. So there is almost minimum side effects with linagliptin, and also mainly a little increased risk of genital infection. Other than that, there is no significant side effect. So this molecule can be used if it is used appropriately, and if we select patients appropriately and use judiciously, and also if you remember the GFR cutoff as well. As of now, we can use it. We can start this medication, any empagliflozin or most of the flozins, if the GFR is more than 30. And especially with empagliflozin, we can continue right up to and most of the flozins which have renal studies as well, right up to the stage of dialysis as per recommendations of KDIGO and American Association of Nephrology. So if we use it judiciously, this can hugely benefit a lot of our patients.
Yes, very well said, sir. Actually, if for any molecule, we have to choose the correct correct population. So, thank you, Devmaloda. Thank you for your kind presence in this discussion with your vast knowledge. Thank you so much. And thank you, Lupin full team, for giving us this opportunity to know and experience the knowledge of sir. Thank you so much. Thank you.
Thank you.